want to take any you don't want to take any more time, so we can start. Hello.
Okay.
Okay, your timer is going on. Please go on.
Okay. Hello, my name is Dr. Galib, and I'm one of the doctors here in the ward. Am I talking to Mr. John Brown, aged 43 years of age?
Exactly, doctor.
Okay, Mr. Brown, we are here to talk about your health condition. And side by side, I'd like to examine you if this is all right with you.
Excellent.
Okay, Mr. Brown, before starting the discussion today, I'd like to know how much do you know about your condition?
My condition, doctor, I have had headache for last 3 days, but for last few hours, my headache get worse and worse, and it's bring me to you.
Okay, I'm really sorry to hear that. So you mentioned about severe headache. So on a scale of 10, how would you rate the pain? How would you
I
rate the
would,
headache?
I would say initially it was about 3, now 7 or 6.
Okay. So is this headache for the first time?
No, I don't. I've had a headache for last few months actually, and few months back, I did have similar episodes of headache, and that was lasted about 3 days. But one thing I can say you, the intensity was different. That was very mild, you can say, but this time I think it's something else.
Okay, so this time the intensity of the headache is very severe, you're saying.
Yeah.
Okay, all right. So, Mr. Brown, would you please tell me where exactly is the headache mostly pronounced? Is it on the center or on the sides,
Wow. I think all of my head.
whole of your head? Okay, so when did it start actually?
This started 3 days back.
3 days back. And for the last few hours, the intensity has increased.
Yes.
Okay, so is it going somewhere else from the head? Like, is it going to your neck or any other parts?
Oh, I don't think so.
Okay. Is there any problem with your vision?
No, I don't have any problem with my vision.
Okay. Any kind of any kind of increased tearing from your eyes or redness in your eyes you noticed in the last three
Tearing?
days?
Tearing? No, no tearing.
No tearing. Okay. Any kind of nasal congestion you noticed in the last few days?
My nose? No,
Okay. And any kind of fever you noticed the last few days?
no kind of fever.
No fever. Okay. And so what in the last 3 days, since your headache started, did you do anything to make it better or just to relieve the headache?
Yeah, I want to tell you that I took some paracetamol from the supermarket. I brought them, but
Hmm.
doctor, there is no difference with paracetamol, and it never happened before with me. Whenever I have headache, I took
Okay.
those medication, and my headache goes away. But
Okay.
I
So
don't know
this
what
time it
this episode. Yeah,
didn't
yeah,
respond
for
to
that.
the paracetamol.
Yeah.
Okay. So, Mr. Brown, would you tell me, is your headache related to any change of your position? Like, is it increasing when you lie down or in standing? Anything like that?
No.
Or any
Nothing.
change with cough? Like when you
No.
give cough, the headache intensifies. Is there anything like that?
No.
Okay. So, is it persistent since last few hours?
Oh, you can say almost always I feel the headache.
Okay, Mr. Brown. Now, I'd like to ask you some general questions regarding your previous episode of headache. So, during your previous episode, how long did your headache usually lasted?
Previous episodes where I said you that 3 months back I have a headache for 3 days,
Mm.
and that was resolved by itself. And now in these episodes I also have headache for last 3 days, but
Okay.
for last few hours it get worse.
Okay.
So one
Okay.
thing should I also volunteer to you that I think at the evening time my headache get worse and more.
Okay. It's about the previous episode you're saying, but this time it has been persistent, right?
Oh, I notice it more on the evening.
Oh, more on the evening. Okay. And Mr. Brown, apart from this headache, do you have any other known medical conditions that I should be aware of?
I recently diagnosed with high blood pressure. My
Okay.
GP prescribed me one medication, which I am taking for last 3 days.
For last 3 days.
Yeah, doctor.
Okay. So would you please show me the medication, or do you know the name of the medication?
Patient show you patient taking amlodipine.
Amlodipine. Okay. For the last 3 days. Okay. And what was your last reading of your blood pressure? Do you know that?
My GP is not happy with my blood pressure. My blood pressure was about 150 by 90.
150 by 90. All right. And do you have any other known illnesses that I should be
No,
aware of apart from
nothing,
the high blood
nothing,
pressure?
nothing.
Nothing. Okay. So, Mr. Brown, I'd like to ask you some general questions. So, apart from the headache, have you noticed any kind of changes in your uh, face, like any kind of rashes?
No, no rashes.
Okay. Any kind of hearing change?
Hearing, no. Fine.
No change. Okay. And any kind of sore throat?
No,
Oh, okay. And have you noticed any kind of weakness in any parts of your body, like arms or legs?
no,
Okay. Any kind of dizziness or any episodes of dizziness or blacking out?
no,
Okay. Okay. And did you notice any kind of shortness of breath or coughing?
no,
Okay. Any racing, pacing of the heart or chest pain?
no,
And any kind of tummy pain or vomiting or throwing up?
no, no.
Okay. And your the water work is all right?
Yeah, fine.
Water work is all right. Okay. So, and what about, did you notice any swelling of any parts of your body?
No,
No. Okay. So, I'd like to ask you about your occupation, Mr. Brown. What do you do for a living?
I'm an IT consultant.
So, I'd just like to ask you some personal question. Is everything in your workplace going on well?
Yeah, everything is fine, but there are lots of stress on my job related to my job.
Okay. Okay. So, is there anything that is causing you anxiety or excessive
I,
stress?
I should not say it's anxiety. I should say the pressure of the work, the pressure load of the
Mhm.
work really get me.
Okay. And what about your family? All members of your family are doing good?
Good,
Any?
fine.
Okay. And what about your traveling history? Did you travel anywhere in the last few days?
Last few days and recently I didn't travel anywhere.
Okay. And have you noticed you're getting paler day by day?
No, no,
Any kind of lumps and bumps anywhere in your body?
no, no,
Okay. Okay. All right. And apart from the medication that you mentioned, amlodipine, are you on any other medication?
I already said you, doctor. I am taking those painkillers. I said you paracetamols.
Okay. Apart from the paracetamol, have you ever taken any other painkillers for a long time, on and
No,
off?
no, never.
Okay. And Mr. Brown, I'd like to examine you now, and side by side, I'll also ask you some few questions.
Please, please.
Okay. I'd like to check the neck rigidity of this patient.
Absent.
Okay. I'd like to check the temperature.
Examiner say the temperature is 98.
98. I'd like to check the visual acuity of this patient and 346 cranial nerve.
Okay, nothing abnormal is detected.
Nothing, no abnormalities. Okay. I'd like to check the fundus of this patient.
Examiner say no need.
No need. Okay. Um, all right. And I'd like to assess the any kind of focal abnormalities. Like I'd like to assess the power of the upper limbs and lower limbs.
So examiner say proceed. You are checking upper limb power. You are checking the lower limb power. Nothing abnormal.
Okay. All right. Mm, okay. And the current blood pressure of this patient?
The current blood pressure is 150 by 90.
150 by 90. Okay. And what about the pulse?
The pulse is 72 beats per minute. You have
72. Okay.
2 minutes
Okay.
remaining.
Okay. I'd like to auscultate the precordium.
Examiner say no need.
No need. Okay. So, Mr. Brown, what are your concerns today?
Am I having tumor?
Okay, Mr. Brown, your concern is absolutely valid, as you have been suffering quite badly with this headache. It's usual that you should be anxious, but currently, as far as we examined you and we took your history, there's currently nothing suggestive of this should could be a tumor or anything like that. As far as we examined you and we talked to you, we have some possibilities in our mind.
Okay. Okay.
Okay, so we'd like to do some
Yes.
baseline tests, and we'd like to keep you under observation, um,
Okay.
so that the sinister causes of the headaches gets excluded, and we can be sure of our diagnosis.
Okay. Just for curiosity, what sort of test you were talking about?
Okay, we'd like to run some blood tests for now,
Okay.
just to check your hemoglobin levels,
Okay.
and uh, also some baseline levels of the salt levels in your body. We'd like to
Okay.
run that. And after that, we'd arrange a meeting with our consultant. And we have a plan that we might run tests called lumbar puncture. Have you ever heard of that?
No, never.
Okay, so it's basically a test where we take fluid that runs in the cavity of our brain and spinal cord from the back. So it is done under after numbing, so that no pain is felt, and there we test actually the fluid to detect any kind of is there if there is any kind of bleeding is there or not.
Okay, doctor, your time is ends. Uh, could you please describe your positive findings and any possible diagnosis for this case?
Okay, so Mr. Brown came with the complaint of headache. It is though he mentions that it is for the second time, but the nature of the headache doesn't actually match with the previous one. This time he had been suffering from headache for the last 3 days, but the intensity has suddenly increased to a level of about 6 to 7
Hmm?
from few hours. From the history, though, he mentions about increase in intensity at the evening, which could suggest tension type of headache. But on the basis of the sudden rise in intensity, um, I would also like to rule out any possibility of any kind of bleeding or subarachnoid hemorrhage.
Okay. So how are you going to investigate this case?
So firstly, I would like to run some baseline tests. I would like to do a complete blood count of this patient, which will help me to detect any kind of anemia present or not. Anemia can increase the headache. I'd like to check the WBC count of this patient, whether there is any kind of infection or not. Like to do the baseline electrolytes. After that, I'd like to run lumbar puncture on this patient after being sure that he is not in any kind of blood thinner medication. There, I would expect bleeding in the CSF.
Okay, how are you going to manage this case?
Um, so I'd like to first give him some. Okay, considering he has also been suffering from high blood pressure, our target would be to follow up his blood pressure time to time, um, and intensify his blood pressure medication if it is needed. And I would like to give him analgesics for controlling his headaches. And after the lumbar puncture
Okay,
is
our
done,
our, our, our discussion time is almost ends. So you did well, uh, I should say. So our exam case was the information we can gather from the scenario is a male, 43 years of age, presented with headache for a few days for a while, and which get worsen for today for last few hours. So when you enter the exam room, so before entering the exam room, Dr. What's your name? Sorry.
Galib.
Dr. Galib, before you entering the room, in PACES exam, they used to give a blank white paper, and we used to write our differential diagnosis before entering the room. And this is a very good practice. And could you please tell me what were your differential diagnosis uh, before entering the room?
My differentials were migraine headache, tension type of headache, a cluster headache, and considering sudden severe headache, I kept subarachnoid hemorrhage in my mind.
Good.
I should also kept pheochromocytoma in the differentials, considering his hypertension and headache, but I actually, I think, forgot to exclude that.
Okay, that was a very good thing, and we will discuss the approach of headache in later part of our discussion. How you differentiate the categories of the headache based on the timing, based on whether it is one episodes or whether there is on and off headache, multiple episodes, and whether there is chronic form of headache. So the differential diagnosis for one-time headache uh, are we all know the subarachnoid hemorrhage, the temporal arteritis, and other things we will discuss later on. But for this case, we can go to the instruction for the surrogate. So here, when you asked how long I have headache, I said you that I for the last 3 days. That was a good question, and I will ask a very important question: whether I am having this headache for the first time. This is a $1 million question. For the first time or previously, I also has had headache. So these question is very important. Why? Because these differentiate the our these will differentiate the broad category of the headache, whether it is on and off headache or whether it is a single episodes of severe headache. So in you know it, the candidates know it that some information the surrogate will volunteer. They will tell you uh, what they are instructed to volunteer at the very early part of the exam. Like I have a headache for last 3 days. for a few hours. It's developed a severe headache, and the headache didn't begin suddenly. So you, 3 days headache means indicates it's happened gradually, but you have to utter the word, is your headache developed all on a sudden, or it's developed gradually? This is a very important question. You need to ask that. For the headache, you didn't ask about the nature of the headache, which was very important. And you sometime you need to give some hints to the surrogate. Do you think it's dull? Do you think it's throbbing, tightness, or hammering in your head, or thunderclap like headache? You have to utter the words when surrogate find it difficult to answer your question. So they will always, for any headache, they will give you a type, a typical type of that headache. So if you ask this question in very part of your exam, I would say to you that I have dull band like headache on both side of my head. It's not like pulsatile for migraine. It not the worst headache of my life. So if you categorize this, that would be helpful. And I would also say to you that if you ask the nature, I would also say to you that it's like a pressure sensation. It's band like, and I did take some paracetamol, but it's has made no difference. And the other informations, if you ask those questions, I should give you the information, otherwise I will not volunteer this information to you. Like, I did experience a similar type of headache 3 months back for a few days, which was similar type of headache, but the intensity was less. And I volunteer one important information, which you don't ask, but I volunteer you that this headache get worse during evening time. And if you ask the triggering factor of headache, so you ask about the red flag triggering, like whether it's increase coughing or sneezing or bending forward. So one advice, so as you were practicing with me, I think you practiced for a long time. Probably you are a mature candidate. So I should say to you that whenever you ask a category of question, similar category of question, ask them together like this. So is this headache increased with coughing, sneezing, or bending forward? So if you ask the whole thing together, when you lie down, when you change your posture, no, you don't need to spend too much time on this. You can ask by one question, and examiner will get you, and surrogate will get you. What do you want to ask and what do you want to exclude? And that will carry a very good impression as well. So other triggering factor, like for migraine, Dr. Gali, what are the triggering factors for migraine, or what are the question you want to ask to exclude the triggering factor of migraine, like long time using computer, phones. So some stress, or sometimes they call it, whenever the stress get relief, like at the end of the week, I feel the headache get worse. So you have to ask the triggering factor as well. uh, the triggering factor should the malignant triggering factor, the red flag triggering factor for all the patient. But for specific triggering factor, suppose in this case you have to ask about the triggering factor of tension type headache. So you all know, for tension type headache, stress is a um, very important triggering factor. So we will come on that. So I also I already said I am an IT expert, IT consultant. So I need to uh, use my computer. I need to spend so many time to watch my monitor, and I I also have very poor sleep. Uh, did you ask about alcohol and smoking, or social
Mm.
is
Missed
social?
that part completely.
You miss that part. You should not, because I think you you did other part very well. So I don't expect you to miss this silly thing. So alcohol is very important. You have to ask about the alcohol. Have to. You have to ask about the stress wherever there is stress, wherever there is stress. Ask about the alcohol history, drinking history, and whenever there is stress, always ask whatever your mood, sir. Could you please describe your mood for last few days? Oh, doctor, I have very low mood. uh, uh, for the few months I am not enjoying my life at all. So mood is very important. So whenever you ask about the mood, ask about the diet, ask about the travel system. I call it mood, diet, travel. Ask them all together. Whatever you describe your mood for last few days. Are you following any specific diet? Do you recently travel anywhere? These questions are very favorite among the RCT examiner. So you also a little bit exploration. I wanted from you to explore the stress on my job. So whenever you found one area of their life is getting stressed, ask about the other area of the life. What about their family life? Any other stress they are having? And at the end, tension type headache usually goes around the stress. So you have to give some advice to the patient regarding the stress. So you could if you could involve the psychotherapist here to relieve the stress, and there are other thing as well. So I would happy to involve those specialists, and if you need some referral regarding the psychotherapist, I would happy to do that for you. So these will be counted for the judgment part of the exam. And if you skip the alcohol part, there is two problem in the exam. So if you miss the driving part, you miss the alcohol part, there is two problem. First of all, they will cut your mark on communication, and they will also cut your mark on clinical judgment, and then can also cut a mark in the safety as well, the welfare as well. So you should not miss the triggering factor at all in any exam or any scenario. For hypertension, yes, I do have hypertension, and I recently diagnosed with hypertension. I recently started treatment with amlodipine. I am taking amlodipine 5 milligram once daily, and my blood pressure is not that fine, and my GP is not happy with my blood pressure. I do smoke. I smoke about 60 cigarettes per day, and as I mentioned you that I am a IT consultant. So IT consultant means I need to spend more time on monitor, and I have two concern. I ask you whether it is tumor. So mm, PACES is a difficult exam, you know it. When you lost the case, you lost so many marks. Why? Because they are linked up to one another. Like if you miss the primary diagnosis, you will not very confident uh, to exclude other diagnosis like tumor in this case. You have to be very confident. uh, I- as I talk to you and examining you, it's not brain tumor. I can reassure that. So examiner wants this line, that you are very confident it's not tumor. And the second concern was, I asked you, I am interested what sort of test you want to do. So you explain the lumbar puncture here, and so before doing lumbar puncture, what we usually do for subarachnoid hemorrhage, Dr. Galib? Are you with me?
We will wait for a period of time for xanthochromia to develop.
Okay, what is the first line investigation for a subarachnoid hemorrhage?
CT,
CT scan. Yes,
CT scan of the brain.
yes, CT scan. So why we do lumbar puncture?
Sometimes there is no hemorrhage on the CT scan. It takes time to develop. Uh, so then after waiting up for 12 hours, then we can find uh, xanthochromia in the CSF.
Okay, you are almost right. So time to develop is not like that. If there is hemorrhage, you can see it on CT scan, because hemorrhage is a bloody thing, and it will get very bright on CT scan. What is the explanation is, for CT scan detecting subarachnoid hemorrhage, the sensitivity is about 90%. So it will miss 10% of the cases in all situation. So for that 10% cases, we need to go for another investigation. We call it the lumbar puncture. We will take some fluid from your back and we'll run some tests. And you are very right. Sometimes this type of communication can come. This type of scenario can come in communication that uh, patient, we did CT scan, but symptom are very suggestive of subarachnoid hemorrhage. So you need to counsel the patient regarding lumbar puncture, and the patient need to wait for about 12 hours. So you're right that we need to wait for the 12 hour to form from the changes which we want to detect in biochemical examination of the CSF. So for examination, your communication skill, I say you miss the alcohol, you miss the smoking, you miss my stress, uh, and the pattern of the headache. I volunteer this information to you. So if a good examiner, they will give you 2 marks here. For physical examination, that was fine, but I would say to you that you need to be in an online situation, or in a only vocal situation. You can say many things, lots of things, but in real exam, or in real patient, doing fundoscopy will take about 1 minute or 1.5 minutes. So for a concised exam, yeah, you need to be very focused. So first you said, I want to check the sign of meningism. Yes, go for the neck rigidity, go for the Carnic sign. Not only check the neck rigidity, we check the neck rigidity, check the Carnic sign as well. So then go down, check the eye. For, as you said, I want to check the 3, 4, 6 cranial nerve, the ocular movement. Before checking ocular movement, you asked about the visual acuity. That was nice, and the ocular movement as well. So why you want to check the ocular movement, doctor? Here, why you want to check the ocular
Mm.
movement?
Yeah, there
Because
is raised
because
ICP.
in
I can
case of,
get false
you can
localization.
find the false localization sign. And you and the eye, if you have or haven't any fundoscopy in the table, you need to utter the word, I want to do fundoscopy. I want to do fundoscopy. There is no PACES exam without checking sign of meningism, fundoscopy, and plantar examination in a patient with headache. We have to do the screening test for all the cases of headache, screening examination in all the cases of headache. So you take the fundoscopy, and most probably examiner will not let you proceed with that. But the important thing is, for neurological examination, you said you want to check the power in both upper limb and lower limb. So my advice is take the power in upper limb only, because exam you will not get very much time. So if you check anything in lower limb, check the plantar. Otherwise, that's fine. So in power examination, in power examination in upper limb is a very vast area. So you need to cut it down. You can check power in elbow, only flexion and extension of the elbow. Can you push me out? Can you push me in? So I think your elbow power is good. You can check it bilaterally. And one thing they write it down, which we usually don't change. They say that this patient also have some neutral neck muscle tenderness. So uh, this is significant actually. In some neurology book, they write it down. The tension type headache usually occur due to the tension type headache is a misnomer actually. So in first time when doctors describe it in literature, they call it tension type headache because they thought it occurred due to excessive tension of the temporalis muscle. that was not right. And but there are some form of tension as well in the muscle of the head and neck area. So you may find this finding in the patient, but I don't recommend you to examine it. But if the patient is above 60 years of age, be aware you need to take for temporal artery tenderness. Uh, that's very significant for that age group. So for physical examination, I would give you 4 out of 4. And for clinical judgment, here is the important thing. Here, as my differential, as my scenario differential diagnosis, first probable diagnosis was tension type headache. I would not discuss about the brain imaging here. If the examiner asks me, in the view of worsening of the headache for last few days, although I doesn't find any other features of sign of meningism, uh, I think you know it. In case of subarachnoid hemorrhage, you also find the symptom of the clinical examination finding of subarachnoid hemorrhage, like neck rigidity, carnic sign. So apart from only sudden worsening of headache, I didn't find any other history sensitive or red flag suggestive of subarachnoid hemorrhage. So I can wait, wait and see the patient. So they also put it in clinical judgment that you have to give me some advice regarding blood pressure control, whether I am taking my medication regularly, smoking cessation, and alcohol. So you can see it here. If you miss alcohol, they will cut you mark in clinical communication skill. If you miss alcohol and smoking, they will cut down your mark in communication skill, and they will also cut down the mark in the clinical judgment as well. And some examiner are bad examiner. They usually cut the whole mark of communication. They will give you some mark in clinical judgment. That's the worst scenario in for a candidate. So, regarding the stress, whenever you identify someone have tension type headache, you need to emphasize the way of relieving the stress. I understand you have a lot of stress on your workplace. You can inform the occupational health therapist of your workplace to talk about your stress, because I think it's involving your health. It's hamper your health. So you have to do something, you have to utter something that sounds like you are doing something, or you are advising something to the patient to relieve the stress, or you are taking the attempt to relieve the stress of the patient. So managing patient concern, I asked about the tumor that was plus minus, and I asked you about the investigation. You describe the lumbar puncture, which was second line investigation for subarachnoid hemorrhage. So I give you tumor, I cut you tumor here. And for identification of physical sign, there was no actually any physical sign. So I give you full mark here as well. For differential diagnosis, you did said this could be tension type headache, so I give you 2 mark here as well. So one important information I want to give you: whenever you diagnose one primary headache, so we have primary headache and we have some secondary headache. So what is the differential diagnosis of primary headache, Dr. Galip? What are the differential diagnosis of primary headache? So we have tension type headache, we have cluster headache, we have migraine, and we have some other very rare form of headache like chronic paroxysmal hemicrania. So we will not go for that. Remember one thing: the best differential diagnosis of a primary headache is another primary headache. The learning is the best differential diagnosis of one primary headache is another primary headache. So if you say my diagnosis is tension type headache, in history you will be very vigilant to differentiate it from migraine. You need to ask about the aura. You need to ask about any abnormal sensation, any abnormal visual sensation, or any abnormal feeling you have before onset of this headache. No, no, nothing like that. So here also important thing, you asked me about the vision problem, but they write it down that I am uh, you have recently changed your reading glass, which is coincide with the onset of the headache problem. So you can take this information and practice this whenever you get a headache case. That um, have you wear glass for have you wear glasses? Yes, doctor, I have glasses. You recently change your glasses? Yes. And sometime when you change your glass, I changed my glass 3 days back. Okay, this could be related to the changing of the glass. So actually, so some some ocular condition may also cause headache, you know it. And the other thing is the drugs is very important. So whenever you in paces, the rules is the if the symptom is coincides with the starting of the drugs, somehow that drugs is related to the symptom. So this is a must know rule. If someone said, though, after starting these thiazide diuretics, I just after one day I started thiazide diuretics 2 1 days back, and now I develop joint pain. So it's gout. So you have to coincide the drugs with the symptom. So whenever someone said you, doctor, I am taking amlodipine. So may I ask when it started? When you started to take this medication? I just started take this medication 3 days back. So this question is very important for the exam. So this was the case. I think you done it well. Just a few tips. You have to explore the headache very vigorously. For headache, uh, we have some question. Usually, we remember the question of headache, question of any symptom by uh, one set course, duration, is there any previous attack, and for headache, we make our differential diagnosis by the frequency of the headache. Give me 1 second time, please. Okay, sorry for the interruption. For headache, as I said, we need to ask about the previous attack. Previously, whether I'm having any headache. Uh, is this episode is similar to the previous episode? You would ask this question as well. This was a very nice question, because sometimes they may say to you, yes, these are not similar headaches. Sometimes what's happened, a migraine patient taking too much medication, and he or she develop medication induced headache. So this thing can happen. This is a very important question. Do you think the headache of this episode is similar to the previous episode you had? So how many attack I am you are having? So I said you that you have to specify that, because it's also have important in migraine prophylaxis. So you have to ask how frequently do you have this headache attack, and what medication you, because invariably patient taking medication for headache. So you have to ask about any medication patient may taking for the headache. Anything brought the headache. So, is there any I said you the coughing, sneezing, bending forward, and for specific time? What is the timing? What is the timing and the headache relationship? It's a very important thing. Some headache occur in morning, and some headache occur usually in evening. So, morning headache usually the obstructive sleep apnea. It will cause morning headache. The raised intracranial pressure. Patient will lie down for a very long time. That will reduce the CSF drainage. That will cause headache, specifically at morning time. And carbon monoxide poisoning, when the patient stay in their home for a long time, they will exposed with the carbon monoxide for a long time, and they will develop headache in the morning. You should also know some neuromuscular disease like myasthenia gravis. When there is respiratory involvement, patient will develop headache specifically at morning time. Why? Because they will retain carbon dioxide, and carbon dioxide can cause headache. So in case of neuromuscular disease like myasthenia gravis or GBS, which where there is a chance of involving the respiratory muscles and carbon dioxide retention headache, you need to specifically ask about the morning headache. So timing of the headache is important. And for the evening headache, what are our differential diagnosis? For the evening headache, we have tension type headache, usually occur at evening. Migraine after the work, sometimes they call it the holiday headache, because after an episodes of stress and they are going home, and during the relaxation time, patient develop headache. And these are important timing of the headache. So these are the exploration of the headache. You have to explore the primary complaint at least 1.5 minute. The learning is this. So in your case, I think you discuss about the headache for only 30 or 45 seconds. You are searching for the diagnosis, you miss the analysis of the headache. So you should not do that. You have to uh, diagnosis is important, but mark is also important. You cannot jump back again to the explanation of the primary complaint. Exploring the primary complaint, they will cut down your mark in history. So you have to explore the headache very vigilantly, and then you need to try to reach the diagnosis. And for headache differential diagnosis, as I said you, in paces we have severe headache, severe one episodes of headache. I call it severe one episodes of headache, like subarachnoid hemorrhage. I remember it by vitamin T, VIT, sorry, vitamin P, vitamin P, VIT, P. So V for vascular. Vascular is like subarachnoid hemorrhage, pituitary apoplexy, and carotid artery dissection, and temporal arteritis. These are the vascular. So subarachnoid hemorrhage, we have giant cell arteritis, we have pituitary apoplexy, and we have carotid artery dissection, and you can also add the cerebral venous sinus, CVST, the cerebral venous sinus thrombosis as well. So these are the vascular cause in which you will get a patient who have headache, very nuanced headache, or one episodes of headache, very severe in nature. So you need to think about that. And for I stand for the infection, the meningitis, and the T stands for the tumor, and the P stands for the pregnancy related, like uh, preeclampsia. And and another P is stand for the post LP headache. So vitamin P is stand for vascular infection, uh, uh, tumor, and pregnancy, and LP, lumbar puncture headache. And this is one category of the headache, and another category is on and off headache. So on and off headache is equivalent to the primary headaches. So whenever someone said you that I have on and off headache, I have similar type of headache 3 months or 6 months back, in a year I have 3 or 4 episodes of this type of headache. So it's very typical. It's never subarachnoid hemorrhage. It could not be subarachnoid hemorrhage. It should be tension type headache. And all tension type headache happen like this. They will comes and goes, and they will comes in attacks. So for we have in on and off headache, we have meningitis, cluster headache, tension type headache, and also the medication is induced headache is also belongs to here. And we have some chronic form of headache. Chronic form of headache, we can remember this as most, MOST. So M stand for the medication overuse headache. This can medication overuse headache can come with migraine or some other primary type of headache for which patient is taking the medication for a long time, and now patient develop a chronic form of headache that persists all the time. And we have obstructive sleep apnea. This can also come present as headache. We have intracranial space occupied lesion, which can present it as long-term headache. and we can have chronic form of tension type headache as well. And for migraine, we all know, for migraine history, we need to ask, like during, before, and after. So what happened before onset of the headache, what happened during the headache, and what happened after the headache. So usually in case of migraine, we have some aura sensation. Although aura is not typical in real life, aura is happen only about 30% of the cases, 30 to 40% of the case. But paces, you will, if you got a case of migraine, you will get aura. And they will give you the feature of aura. Aura is very suggestive of migraine in paces exam. Until prove otherwise, that will um, indirectly diagnose the migraine. So you need to ask, what before onset of the headache, have you experienced any abnormal visual sensation, any strange feeling, any nausea feeling, or any GI problem you are having. And during the episodes, do you find it difficult to cope with bright light, loud noise? You need to ask this question. So after the headache, you need to ask the question that is it resolved spontaneously, or have you taken any medication uh, to reduce the headache. For cluster headache, you did exclude the cluster headache. That was fine. You asked me about the red eye. So again, I advise you, whenever you ask one category of question, ask them all together. So in case of cluster headache, we have five questions, like red eye, stuffy nose. Nasal congestion is a bit hard term, so you can say stuffy nose. Any dropping of the eyelid. In case of cluster headache, you may have partial ptosis or ptosis. And how frequent you, in case of cluster headache, the patient will experience very frequent headache episodes. And for tension type headache, whenever you heard that this headache worsen in evening, you have to ask these three questions all together. What the nature of this headache? When I know that it's a dull type of headache, yes, you have dull type of headache. Could you please describe what the nature of this headache? Is it band like or squeezing? Oh, yeah, doctor, yes, a band like. Okay, is it Horsen in evening? Yes, 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 doctor, it's Horsen in evening. Do you have any, may I ask a personal question? Do you have any stress in your life or in your job? Yes, doctor, I have. Yeah, at the very beginning, you will catch the diagnosis and you will get relaxed that you have got your diagnosis. Now you have to exclude other diagnosis according to the history. So the learning here is, don't take history haphazardly. We have four questions for tension type headache. You need to ask all these four questions together. So if you find one positive, you need to ask other question as well. So is it dull? Is it band like? Is it worsen on the evening? And is there any stress on your life, stress in your life, or related to your job? uh, I think I almost cover all the primary headaches. There is also another form of someone categorizes as primary headache in some books, the trigeminal neuralgia, although it's very rare in cases. But in case of multiple sclerosis, one of the very important finding or very important early feature of multiple sclerosis could be trigeminal neuralgia. So, what question we need to ask about trigeminal neuralgia? For trigeminal neuralgia, you need to ask about the, is this pain shock like in your face, or is it brought by touching or brushing? The trauma can trigger uh, uh, the pain of trigeminal neuralgia. So remember the learning from this case, for a primary headache, always try to put a other primary headache as differential diagnosis. When you find one primary headache, like episodic headache, you need to exclude all the primary headaches by asking the group questions altogether. So by this, you can reach your diagnosis very early, and it will help you to get full mark in consultation station. So this was our case today. uh, Anyone have any question? Hello, hello. So thank you, doctor, for give your time to me, and it's also a pleasure to me to interact with you. And thanks to the doctor who practices a candidate. Uh, um, Always practice vigorously for the PACES exam. So the more you practice, the the better we will get. The more structure way you practice, the more better you will get. And I always advise all the candidates, you need to practice the ideal cases first. So I took this case from real RCP scenario, and when you solve all the scenarios of all the RCP scenarios from their website, you will have a very good idea how they form the question and what they want from the examinee, what exact thing they ask from the examinee. So if you practice like this, you will get not only very fluent, but you will have a very good idea um, to get better in long clinical consultation. So, as there is no question, I thank you everyone for the participation. Thank you very much.
Thank you. It was a wonderful session.
Thank you, doctor. Actually, you did well. I should say that you did well.
The problem is that I actually miss the format and structures
Yes,
sometimes.
yes, yes, yes. You need to be your own. So during the exam, examiner will examine you. But before the exam, you need to examine yourself day in and day out. So find when you find your fault, say Alhamdulillah, I find one fault of mine.
Yes.
Uh, because the first step of correction is finding it out. So I find out my fault. That's a very good thing. So write it down and improve it. Thank you very much, doctor.
Thank you, man.